So, imagine a surgeon in the emergency room. It is, let's say it's 2 in the morning.
Right, the classic ER scenario.
Exactly. And they are staring at a monitor, guiding a laparoscopic camera through a patient's abdomen.
Uh-huh.
The target is this organ that has been causing just agonizing right lower quadrant pain for 2 days.
Standard acute appendicitis presentation.
Right. And when the camera finally illuminates the appendix, it is an absolute mess.
Oh, I'm sure.
It's swollen to like 3 times its normal size, angry red, completely encased in this thick layer of yellow pus and friable tissue.
Yeah, that tissue gets incredibly fragile.
So the surgeon meticulously snips it out, washes the abdominal cavity, and closes the patient up.
A standard successful emergency surgery.
Right. They wash their hands, go talk to the family, tell them the surgery was a success. They think they just saved a life from a routine burst appendix.
But there's a catch.
A massive catch. What that surgeon doesn't know, and honestly won't know for several days, is that hidden beneath all that acute inflammation is a microscopic time bomb. By removing that appendix, they might have just cured a hidden cancer. Or, depending on how they handled the tissue, they might have just triggered its spread.
It is, honestly, one of the most unsettling scenarios in modern general surgery.
It really is.
I mean, we rely so heavily on visual confirmation in the operating room,
Yeah.
but the gastrointestinal tract and, the appendix in particular has this terrifying ability to mask complex pathology.
It hides behind the simple, loud symptoms of an infection.
Exactly. Behind the very loud alarm bells of acute infection.
Well, that is the exact mystery we are unpacking today. Welcome to the deep dive.
Thrilled to be here.
Today, we are taking a massive stack of medical literature. We are talking about the new AJCC version 9 staging guidelines, some major genomic sequencing studies out of the National Cancer Institute, surgical oncology textbooks, and some really pivotal recent meta-analyses.
It is a lot of dense material.
It is, but we are synthesizing all of it to understand appendiceal tumors.
Which is such a misunderstood topic.
Right. Our mission is to figure out how an organ, famous for doing absolutely nothing but getting infected, can harbor some of the most genetically unique neoplasms in the human body.
Yeah, to really set the baseline here, we need to understand the scale of what we are dealing with.
How common is this, really?
Well, if you look at the broad epidemiological data over the last few decades, these tumors are considered incredibly rare.
Like lightning strike rare.
Sort of. Historically, they are found in roughly 0.9 to 1.4% of all appendectomies performed.
Wow. Okay, so less than 2 in 100.
Right, so for a long time, they were just treated as a surgical oddity, a literal footnote in a pathology textbook.
But that is changing, right?
Oh, absolutely. The data is shifting rapidly. Their incidence is rising.
And that rising incidence is, it's colliding with a massive diagnostic challenge.
Because they mimic appendicitis.
Exactly. As we set up in that opening scenario, these tumors don't announce themselves as cancer. They almost perfectly mimic standard acute appendicitis.
Down to the last symptom.
So whether you are a medical professional trying to understand the latest staging protocols, or you are just someone fascinated by how the human body breaks down, we are going to walk through the entire life cycle of this disease.
From the ER to the genetics.
Right. From the initial misdiagnosis in the ER to the cellular biology to the incredibly intense surgeries required to fix it.
And the best place to start is right where you began, in the emergency room.
Yeah, let's go back there.
Because if these tumors are masquerading as appendicitis, we really need to understand how they are actually discovered in the real world.
Which usually isn't until days later, right?
Exactly. Historically, and honestly even today in many centers, we don't find them until the excised tissue is sitting under a microscope days after the patient has gone home.
I remember reading about that Spanish cohort study in the materials.
Yes, that is a key retrospective cohort study from a single center in Spain that illustrates this perfectly.
They looked at, what, like 1,400 appendectomies?
1,434 to be exact, over a 5-year period.
Let's break down the reality of a retrospective study like that. They are looking backward at these 1,400 patients who already had their appendix removed.
Right.
What was the demographic? I mean, were these people coming in for planned surgeries?
No, and that is the crucial context here. 96% of these surgeries were emergency procedures.
Oh, wow.
Yeah, these were people walking into the ED in agonizing pain with elevated white blood cell counts, fevers, nausea.
The classic textbook presentation.
The absolute classic. And the clinical teams, treated them exactly as such.
But the pathology report said something different.
You did. When the pathologist took those 1,400 specimens, sliced them thin, and put them under the microscope, a definitive appendiceal neoplasm was found in 3.2% of the cases.
Wait, hold on. Pause on that number.
I know, it's a big jump.
You just said the historical average is around 0.9 to 1.4%. Finding tumors in 3.2% of emergency appendectomies is a massive leap.
It is.
That means out of every 100 burst appendixes coming through those doors, 3 of them are actually cancer.
It is a really significant jump, and it reflects both a true rise in incidence and, frankly, better pathological analysis. We are just looking much closer now.
But the really staggering finding in that Spanish study wasn't just the numbers.
No, it was the complete lack of intraoperative awareness.
The surgeon's blind spot.
Exactly. In this study, the researchers cross-referenced the final pathology reports with the operative notes dictated by the surgeons immediately after the procedures.
And what did the surgeons write?
They described the severe inflammation, the pus, the necrotic tissue. But out of all those cases that turned out to be tumors, there were 0 intraoperative reports noting free mucus in the abdomen.
0.
0. Furthermore, there was absolutely no statistical correlation between what the surgeon saw with their own eyes, like an unusually firm mass or a weirdly shaped appendix, and the final diagnosis of a tumor.
I want to push back on that because I think a lot of people listening are wondering how that is even physically possible.
It sounds counterintuitive.
Yeah, right. I mean, a surgeon has a high-definition laparoscopy camera right inside the abdomen.
Yes.
They are manipulating the organ with physical instruments. They are highly trained anatomists.
They are.
So if there is a tumor growing inside the appendix, how do they completely miss it while they are looking directly at it?
It really comes down to the gross pathology of acute inflammation. It is just visually overwhelming.
Oh, so?
Imagine trying to identify the make and model of a car that is currently engulfed in a raging fireball.
Oh, that's a good analogy.
You can't see the badge on the hood, you just see the fire.
Right.
When an appendix is acutely inflamed, it doesn't just get a little red, the walls swell dramatically with edema.
So it's waterlogged.
Exactly. And it becomes covered in this thick, sticky layer of yellow fibrin and purulent exudate.
Basically pus.
Yes, pus. And the tissue becomes incredibly friable, meaning it is so fragile and engorged with blood that merely touching it with a surgical grasper can cause it to tear and bleed.
So the surgeon isn't gently exploring the organ.
Not at all.
They are basically trying to defuse a bomb.
That is the perfect way to frame it. The surgeon's primary overarching goal in that moment is infection control.
Just get the infection out.
Right. They need to detach this rotting, infected organ from the cecum and get it out of the sterile abdominal cavity without spilling its highly toxic contents.
So they aren't looking for a tiny tumor.
Exactly. They are not taking a scalpel and meticulously dissecting the layers of the appendix wall, looking for a firm 1 centimeter submucosal nodule. The massive inflammation completely masks the underlying architecture.
Okay, yeah, that makes terrifying sense. The environment of the ER totally dictates the surgeon's focus.
Exactly.
So they take it out, send it to the lab, and then the pathologist finds the tumor.
Yes.
But what kind of tumors are we talking about here? Because the literature suggests the types of cancers we are finding are actually changing.
They are changing quite a bit. If we look back a few decades, the overwhelming majority of appendiceal tumors discovered, incidentally, were neuroendocrine tumors.
We usually abbreviate those as NETs, right?
Correct. But the epidemiology has undergone a major shift. Today, epithelial tumors, and specifically mucinous neoplasms, are dominating the landscape.
By how much?
Well, in that same Spanish cohort we just discussed, epithelial tumors made up 68% of all the neoplastic cases.
Wow, so a huge majority.
Yes.
I want to conceptualize why these tumors specifically cause the symptoms of appendicitis.
It's an important mechanical question.
Right, because if a patient has a tumor growing on their kidney or in their lung, it doesn't usually present as a sudden, agonizing acute infection.
No, it doesn't.
Why does an appendiceal tumor cause the appendix to essentially burst?
To understand that, we have to look at the unique plumbing of the appendix.
The plumbing. Right. The appendix is basically a sealed pipe, a blind-ended tube.
Exactly. It has only one connection to the rest of the gastrointestinal tract, and that is a very small opening into the cecum.
Which is the beginning of the large intestine.
Yes. So imagine a tumor begins to grow inside the wall of that narrow tube. As it expands, it encroaches on the lumen, the empty space inside the pipe.
It narrows the passageway.
Or in the case of these mucinous tumors, they start pumping out incredibly thick, jelly-like mucin.
So either way, the physical mass of the tumor or that dense mucin acts like a cork.
Yes. It completely plugs the only exit.
But the lining of the appendix doesn't know it's plugged, right?
No, it's completely unaware.
It's still functioning, still producing its normal daily mucosal secretions.
Precisely. The mucosal lining continues to secrete fluid, but now that fluid has absolutely nowhere to go. The cork is firmly in place.
So the pressure inside the blind-ended pipe just begins to build rapidly.
And that pressure is exactly what triggers the cascade. As the pressure rises inside the tube, it pushes outward against the walls.
I'm guessing that affects the blood flow.
Severely. That outward force compresses the tiny veins running through the appendix wall. The venous blood can't drain out, so the organ becomes congested and swollen.
But the arteries are still pumping blood in.
Exactly. The arterial blood, which pumps at a much higher pressure, keeps forcing its way in, making the swelling even worse.
It's a vicious cycle.
It creates a cycle of profound ischemia. The tissue is literally starved of oxygen because the blood flow is totally disrupted by the pressure.
And when tissue dies, infection sets in.
Right. As the tissue starts to die, the normal bacteria that live peacefully inside the gut suddenly find themselves trapped in a stagnant, oxygen-deprived pool of fluid.
A perfect breeding ground.
They multiply exponentially. The body responds by sending white blood cells to fight the infection, which creates pus.
And then the wall gives out.
The walls weaken, the inflammation reaches the outer layer, the serosa, and rubs against the inner lining of the abdomen.
Which causes that severe localized pain. And boom, it looks, feels, and acts exactly like acute appendicitis.
Because it is acute appendicitis, but it is secondary appendicitis.
Secondary because the infection is just a mechanical symptom of the primary neoplastic problem.
The tumor is the root cause. The infection is just the really loud alarm bell that brings the patient to the hospital.
Okay, so we've established the macroscopic view. The plumbing is blocked. The pipe bursts. But let's zoom way, way in. If we move from the surgical suite to the pathology lab, what is actually happening at the cellular level?
Well, pathologists methodically divide appendiceal tumors into two main histological buckets based on their cellular origins,
Which are?
non-epithelial and epithelial.
Yeah.
And the biology of where the tumor starts dictates entirely how it will behave in the patient.
Let's tackle that non-epithelial bucket first. You mentioned neuroendocrine tumors, or NETs. Where do those come from?
NETs originate from enterochromaffin cells.
Enterochromaffin cells. Okay, give us some context on those.
Sure. Enterochromaffin cells are scattered throughout the lining of your entire digestive tract. They are part of the neuroendocrine system.
Meaning they bridge the nervous and endocrine system?
Exactly. They receive signals from the nervous system and respond by releasing hormones directly into the blood.
What kind of hormones?
In the gut, their main job is to produce chemicals like serotonin, which actually helps regulate intestinal motility.
So muscle contractions that move food along. So a neuroendocrine tumor is essentially a cluster of these serotonin-producing cells that have just started dividing out of control.
Correct. And when a pathologist looks at a net under a microscope, it has a very distinct, almost orderly appearance.
Orderly. Usually cancer looks chaotic.
I know, but these cells are uniform, and the DNA inside their nucleus has a very specific pattern that pathologists describe as salt and pepper chromatin.
Salt and pepper chromatin.
Yeah, it looks like finely stippled black and white dots, and anatomically, there's a weird quirk.
What's the quirk?
These nets almost exclusively decide to grow right at the very tip of the appendix.
Just at the tip. And as far as cancers go, they are usually on the less aggressive end of the spectrum, right?
Generally, yes. They're often described as indolent. They grow quite slowly, and if they are small, just removing the appendix is usually a complete cure.
Okay, that's the non-epithelial bucket. But the other bucket, the epithelial tumors, that represents a completely different and far more chaotic biological beast.
It really does.
Yeah. Epithelial tumors. These are the ones originating from the cells that line the inside of the pipe.
Specifically, they heavily involve goblet cells.
Goblet cells.
Yes. Goblet cells are specialized epithelial cells shaped like little cups or goblets. And their singular purpose in life is to secrete mucin.
Mucin, the famous jelly. Let's talk about mucin, because normally it's not a bad thing, right? We actually need mucin.
It is essential for health. It acts as a protective barrier for the lining of the stomach and intestines.
It lubricates the passage of food. It traps harmful bacteria.
Exactly. It even prevents our own stomach acid from digesting our organs. It is a vital biological shield.
But in an epithelial appendiceal neoplasm, the genetic programming of those goblet cells just goes completely haywire.
They lose their regulatory off switch entirely. They begin to produce mucin endlessly in massive, massive quantities.
So what was supposed to be a protective microscopic layer becomes a literal weapon of mass expansion.
That is exactly what happens. The sheer volume of thick jelly physically stretches the walls of the appendix outward.
Like a water balloon filling from a hose.
Yes, and this creates a clinical entity we call a mucocele, which literally translates to a mucus-filled cavity.
And here is where we hit a massive historical blind spot in oncology.
Oh, a huge one.
For decades, if a patient had one of these advanced epithelial appendix cancers and the mucin had spread, oncologists essentially shrugged and treated it exactly like colon cancer.
They did. They gave these patients the standard heavy-duty colorectal chemotherapy cocktails.
Which sounds crazy now. Why did they do that?
Well, the reasoning made anatomical sense at the time. The appendix is physically attached to the cecum.
Right.
It is embryologically derived from the midgut, just like the right side of the colon, and the cells look somewhat similar under a microscope.
So the assumption was that the underlying cellular biology, the engine driving the cancer, was the same.
Exactly.
But it wasn't. And this brings us to one of the most important papers in our stack of sources.
The NCI study.
Yes. A massive paradigm-shifting study from the National Cancer Institute that completely rewrote the rulebook on how we understand this disease.
It was a true watershed moment in oncology.
Yeah.
The NCI partnered with Foundation Medicine to utilize their highly advanced genomic sequencing technology.
Okay, so instead of just looking at the cells under a microscope to see their shape,
They cracked open the DNA. They took tumors from 703 patients with appendiceal cancer, and they sequenced over 300 different cancer-associated genes.
they were mapping the exact genetic mutations driving the disease.
Yes.
Now, when you say they sequenced 300 genes, what are they actually looking for? Because mutation is a broad term. Are they looking for missing chromosomes, misspelled DNA code?
They are looking for specific alterations in the genetic code, so substitutions, deletions, or amplifications in genes that are known to control cell growth, division, and death.
The blueprints.
Right, the blueprints that tell a cell when to multiply and when to stop. The NCI study basically wanted to see if the blueprint for appendix cancer matched the blueprint for colon cancer.
And the results proved definitively that they are not the same.
Not even close. It wasn't just a subtle variation. It was a fundamentally different molecular fingerprint.
Let's look at the specific data, because the contrast is stark. The researchers found incredibly high rates of mutations in two specific genes in the appendiceal tumors.
KRAS and GNAS.
Yes, KRAS and GNAS. Depending on the exact subtype of the appendix tumor, KRAS was mutated in anywhere from 38% to 100% of cases.
And GNAS was mutated in 17% to 100% of cases.
Okay, let's translate that out of genetic jargon for the listener. What does KRAS actually do in a normal, healthy cell?
In a normal cell, the KRAS gene produces a protein that acts as an intricate on and off switch for cell growth.
Oh, okay.
When the cell receives a signal from the body that it needs to divide, say, to heal a cut on your skin, the KRAS protein flips to the on position, transmits the signal to the nucleus, and then quickly flips back to the off position.
It's a very controlled gas pedal.
Yes, exactly. But when the KRAS gene is mutated, the protein it produces is physically deformed. It loses the ability to turn off.
Oh, so it's stuck.
It gets permanently stuck in the on position. It constantly screams at the cell to divide, 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 even when the body doesn't need new cells.
And that leads to unchecked tumor growth.
Exactly.
And what about GNAs?
GNAS is another signaling gene, but it is heavily involved in the pathways that drive cellular secretions.
Secretions, like mucin.
Exactly. A mutated, hyperactive GNAS gene essentially hotwires the goblet cells, forcing them into overdrive to produce that massive, endless supply of mucin jelly we talked about.
So appendix cancer is driven by a broken gas pedal for growth and a broken switch that just floods the entire area with mucin.
Right.
But the NCI study also looked at the genes that weren't mutated, right?
And that was the smoking gun. While KRAS and GNAS were mutated off the charts, mutations in two other genes, APC and TP53, were remarkably rare in the appendiceal tumors.
Why does the absence of those mutations matter?
Because mutations in APC and TP53 are the absolute hallmarks, the defining genetic signatures of standard colon cancer.
Oh, I see.
TP53, for example, is literally known as the guardian of the genome. It's the master brake pedal.
So if a cell's DNA is damaged,
TP53 stops the cell from dividing and forces it to repair itself or commit suicide. In colon cancer, That break line is almost always cut.
But in appendix cancer,
In appendix cancer, the break line is usually intact, but the gas pedal is stuck.
it's a completely different mechanism of failure.
Entirely different.
So if the NCI proved this is genetically distinct from colon cancer, what does that mean for the patients who had been getting colon cancer chemotherapy for the last 20 years?
It means we were fundamentally failing them. We were basically using the colon cancer key to try and unlock an appendiceal cancer lock.
It just doesn't fit.
No. Traditional systemic chemotherapy targets the specific growth pathways of colon cancer. Because those pathways aren't the primary drivers in appendix cancer, the drugs often had terrible response rates.
So we were giving patients massive toxicity with very little oncological benefit.
Unfortunately, yes.
But the NCI study doesn't just point out the historical mistake, right? It provides the map for the future. By knowing the exact genetic mutations, oncologists can now pivot to targeted therapies.
Precisely. For instance, the study noted a small subset of appendiceal tumors have a genetic condition called MSIH.
High microsatellite instability.
Yes. Essentially, these tumors have a defective DNA repair mechanism, so they accumulate thousands of mutations, making them look very foreign to the body's immune system.
That sounds like a good thing, though, if the immune system can recognize it.
It would be, however, the tumor produces a protein shield to hide from those immune cells.
So the immune system knows something is wrong, but it can't engage.
Right. But now, because we can sequence the tumor and identify the MSIH status, we can use targeted immunotherapies like pembrolizumab.
And what does that do?
This drug specifically strips away the tumor's protein shield. It takes the brakes off the patient's own immune system, allowing T cells to swarm and attack the appendiceal tumor with incredible efficacy.
It is a brilliant example of how unlocking the genetic code completely alters the trajectory of treatment.
Absolutely.
But let's take a step back from the DNA level.
Sure.
Knowing the genetic fingerprint is fantastic, but it requires a physical piece of tissue to test.
Right. You need the biopsy.
How do we catch this disease before it bursts, before it ends up in a pathology lab? If a patient comes into the clinic with weird abdominal pain, is there a way to see the tumor coming?
That is the diagnostic holy grail we are chasing, and right now the reality is that we are really struggling.
Still, with all our imaging.
Yeah. Our current imaging technology has severe limitations in the acute setting. We need to discuss the CODEA trial, which is a landmark randomized study that highlights this exact problem.
Tell me about the CODE trial. Who are they looking at?
The researchers analyzed a massive cohort of 2,062 adult patients who arrived at the hospital with acute appendicitis.
Okay, big sample size.
And every single one of these patients had their diagnosis confirmed by a CT scan. The radiologist reviewed all the scans and flagged the ones they thought looked highly suspicious for a hidden appendiceal tumor.
And eventually, all these patients had their appendix removed, giving the pathologist the final, definitive answer.
Correct. The pathology report served as the absolute truth. And out of those 2,062 patients, 12 were found to actually have an appendiceal tumor.
Only 12. Wait, so how did the radiologists fare? Were the CT scans able to predict those 12 cases?
Well, let's look at the statistical performance. The negative predictive value, or NPV, of the CT scans was 99%.
Meaning?
This means that if the radiologist looked at the scan and said, this is just standard infection, there is no tumor here, they were right 99% of the time.
That sounds incredibly accurate. If the scan says no tumor, you can breathe easy.
Yes. But the problem lies on the other side of the equation. The positive predictive value, or PPV, was a dismal 23%.
Wait.
Yeah.
So if the radiologist looked at the CT scan and explicitly said, I see a mass here, I suspect a tumor, they were wrong nearly 80% of the time.
Exactly. They were overwhelmingly generating false positives.
How is that possible?
It's not because the radiologists lacked skill. It is a fundamental limitation of the modality. On a CT scan, you are looking at variations in tissue density using X-rays.
Right.
But a severely inflamed edematous appendix swollen with trapped fluid, surrounded by inflamed fat and covered in reactive scar tissue, looks anatomically indistinguishable from a mucinous tumor.
It's just a big gray blob on the screen either way.
Exactly. The imaging simply isn't specific enough to reliably separate the noise of inflammation from the signal of cancer.
So if the CT scan can't give us a clear answer, there has to be some kind of clinical red flag.
There is.
Some clue in the patient's presentation that makes the emergency physician or the surgeon stop and think, this might not just be a piece of hardened stool blocking the appendix, this might be a neoplasm.
There is a major red flag, And it brings us to a critical meta-analysis published recently in Frontiers in Oncology.
Okay.
This paper completely reshaped how we risk stratify appendicitis patients based on one specific severe complication,
Which is?
the appendiceal abscess.
Let's define an abscess for the listener, just to be clear on the terminology.
Sure. When the appendix becomes obstructed and bursts, it spills infected pus and fecal matter. If this spills freely everywhere, it causes generalized peritonitis, which is life-threatening.
Right.
But often, the body's immune system tries to contain the spill. The surrounding intestines and a fatty apron called the omentum rush in and wrap around the burst appendix.
Like a biological blanket?
Exactly.
Yeah.
Walling off the infection into a localized, pressurized pocket of pus. That walled-off pocket is a periappendiceal abscess.
Okay, so the Frontiers meta-analysis looked at patients who presented with these abscesses versus those who didn't. What was the risk difference?
It was night and day. If you present with uncomplicated appendicitis, meaning the appendix is inflamed but still perfectly intact, no rupture, no abscess, your risk of having a hidden tumor is tiny.
How tiny?
It hovers at less than 2%.
Very reassuring for the vast majority of patients.
But if you present with complicated appendicitis featuring an abscess, the risk of an underlying neoplasm skyrockets to between 10 and 15%.
That is a massive jump, from under 2% to potentially 15%.
Yes.
Why is the presence of an abscess such a strong indicator of a tumor?
It goes back to your plumbing analogy from earlier.
Yeah.
The most common cause of standard appendicitis is a fecalith.
A small, hardened piece of stool that gets wedged in the pipe.
Exactly. Sometimes, as the appendix swells, that fecalith can dislodge, or the pressure can relieve itself before a catastrophic blowout.
But a tumor is different.
A tumor is a robust, unyielding biological cork. It creates a chronic, absolute obstruction. It is not going to dislodge.
So the pressure just keeps building.
Therefore, it is far more likely to drive the internal pressure so high that the appendix suffers a high-pressure rupture, leading to a massive inflammatory response and abscess formation.
I want to run a couple of clinical what-if scenarios to really test this logic.
Let's go.
Because reading through the literature, it becomes incredibly clear that you cannot apply that 15% rule universally. Age seems to be the ultimate arbiter here.
Age is, without a doubt, the single most critical variable in risk stratification for these tumors. What's your scenario?
Scenario A. A 12-year-old child comes into the pediatric ER. They've had worsening belly pain for 3 days. They are spiking high fevers. They can't eat.
Okay.
The ultrasound and CT scan show a ruptured appendix with a massive 5-centimeter abscess. According to the data, does that child have a 10 to 15% chance of harboring an epithelial appendix cancer?
Absolutely not. And this is vital for pediatricians and, frankly, terrified parents to understand.
So they shouldn't panic about cancer.
No. Extensive pediatric cohorts, notably the China trial, have exhaustively studied this. There is zero statistical association between appendiceal abscesses and epithelial cancer in children. The risk is effectively zero.
So what is causing the massive abscess in the 12-year-old?
In children, an abscess is almost always due to a delayed presentation of simple bacterial appendicitis. Kids often can't articulate their pain early on, or parents might mistake it for a stomach bug for a day or two.
So by the time they get to the ER, it's already popped.
Exactly. Alternatively, kids frequently suffer from profound lymphoid hyperplasia.
Lymphoid hyperplasia, that's when the immune tissue inside the wall of the appendix swells up in response to a viral infection, like a cold, and accidentally blocks the tube.
Exactly. The swelling creates the obstruction, leading to appendicitis. Now, to be thorough, it is technically possible for a child to have a tumor, but it is astronomically rare.
And if they do?
When it does happen, it is almost exclusively a tiny, incidental neuroendocrine tumor net that is completely cured just by removing the appendix. But they do not get the aggressive mucinous cancers.
Okay, huge sigh of relief for scenario A. But let's flip the demographics for scenario B.
All right.
A 45-year-old adult walks into the ER, exact same presentation. 3 days of pain, fevers, elevated white count. The CT scan shows an identical ruptured appendix with a large walled-off abscess.
That patient is in the absolute danger zone.
Really? Just based on age?
Over the age of 35 to 40, the incidence curve for these tumors spikes dramatically. For that 45-year-old with an abscess, the clinical team must have a very high index of suspicion for an underlying neoplasm, specifically a mucinous neoplasm or an invasive adenocarcinoma.
So how does that high suspicion change the immediate treatment plan in the ER? Because historically, the reflex in surgery has always been inflamed appendix equals immediate operation.
And that reflex is exactly what is changing. We are currently in the midst of a major shift in surgical philosophy regarding complicated appendicitis. We are moving towards a protocol called interval appendectomy.
Let's walk through what that actually means. The 45-year-old is lying in the bed with an abscess. If the surgeon doesn't take them to the operating room right then, what is the alternative?
Well, operating in the acute phase of an abscess is incredibly hazardous.
Because of the inflammation.
Yes. The surgeon is diving into a pelvis filled with dense inflammatory scar tissue, active infection, and incredibly fragile bowel loops.
Right.
The risk of accidentally damaging the adjacent colon, creating a bowel leak, a fistula, or spreading the infection throughout the entire abdomen is unacceptably high. So the alternative is non-operative management initially.
You treat the fire with water before you try to rebuild the house.
Precisely. You admit the patient to the hospital, you put them on powerful, broad-spectrum intravenous antibiotics.
And what about the pus?
If the abscess is large enough, you have an interventional radiologist use an ultrasound to guide a small drain through the skin directly into the pocket of pus to siphon it off.
Oh, I see.
You let the body's immune system calm down, the fever breaks, the pain resolves, the patient goes home.
And then what? You just leave the ruptured appendix inside them?
No. You wait 6 to 12 weeks. During this time, the dense inflammatory scar tissue melts away, the anatomy returns to normal.
Okay.
Then, you bring the patient back to the hospital as an outpatient for a planned, highly controlled surgery to remove the appendix. That is the interval appendectomy.
And tying this back to the 15% cancer risk, this wait-and-see approach isn't just about avoiding a surgical complication like a bowel leak, is it?
No, not at all.
It's an essential oncological strategy. It's a fact-finding mission.
It is arguably the most important decision in the patient's oncological journey. By waiting for the inflammation to subside, the surgeon can actually see what they're doing.
Because the fire is out.
Exactly. When they put the camera in during an interval appendectomy, the appendix is calm. If there is a firm mass at the base of the appendix, they can clearly identify it.
And they can remove it safely.
Most importantly, they can safely dissect and remove the entire appendix intact without rupturing it during the extraction.
Why is keeping it intact so critical?
Because if the surgeon is wrestling with a severely inflamed appendix during an emergency surgery, and it accidentally tears or bursts while they're trying to pull it out, and that appendix happens to contain a mucinous tumor, they have just spilled viable cancer cells and mucin throughout the patient's abdominal cavity.
Oh, no.
They have essentially turned a localized, easily curable stage 1 tumor into a disseminated, potentially fatal condition. Interval appendectomy minimizes that risk.
It allows for a clean resection.
Yes.
Okay, so let's follow the tissue. The surgeon performs the interval appendectomy successfully. The organ is out, intact. They put it in a container of formalin and send it off to the pathology lab.
This brings us to the pathologist's domain.
Right. And reading through the sources, it seems like the entire rulebook for how pathologists grade and classify these specific tumors was recently torn up and rewritten.
It was a seismic shift in the field of gastrointestinal pathology. In January 2022, the American Joint Committee on Cancer, the AJCC, rolled out version 9 of their staging system for appendiceal tumors, working in tandem with updated classifications from the World Health Organization.
I want to focus heavily on two specific acronyms that pop up continuously in the literature because they seem to be the absolute focal point of these new rules. LAMN and AJCC. Let's unpack those.
Okay, so LAM stands for Low-Grade Appendiceal Mucinous Neoplasm, and AJCC stands for High-Grade Appendiceal Mucinous Neoplasm.
So they are both from that epithelial bucket.
Yes, they are both epithelial tumors derived from those mucin-producing goblet cells we discussed earlier. The difference is how aggressive the cells look under the microscope.
What was the massive change in the version 9 guidelines regarding LAMNs and HAMNs?
Well, prior to January 2022, there was a lot of debate. Many pathologists classified LAMNs and HAMNs as borderline tumors, or tumors of uncertain malignant potential.
So they weren't considered cancer?
They weren't considered outright cancer in the traditional sense, no. But the new AJCC version 9 and WHO rules mandate a hard line.
Which is?
These are officially malignant tumors. They are classified as either in situ or invasive carcinomas, and as of 2022, a diagnosis of LAMN or HAMN must be legally reported to national cancer registries.
I have to ask why. If a pathologist looks at a LAM and the cells are low grade, meaning they look relatively well behaved, not like highly mutated aggressive cancer cells, why forcibly upgrade their status to officially malignant?
Because of how they behave macroscopically in the patient. And this brings us to a fascinating biological quirk of llamas that makes them so uniquely dangerous.
How do they behave?
We have to compare them to typical cancers.
Let's use colon cancer or breast cancer as the baseline.
Perfect. Standard adenocarcinomas in the colon or breast exhibit what we call infiltrative growth.
Infiltrative. I imagine that, like, tree roots tearing aggressively through soil.
That's a great visual.
The cancer cells produce enzymes that break down the surrounding healthy tissue, actively invading and destroying blood vessels and muscle fibers as they spread outward. It's destructive and jagged.
That is an excellent analogy. But lamins do not do that. The cells themselves do not actively chew through the appendix wall.
Then how do they spread?
Instead, lamins exhibit what pathologists call pushing invasion.
Pushing invasion. Okay, so if infiltrative invasion is like tree roots tearing through soil, pushing invasion is like a balloon inflating inside a closed fist.
Precisely. Let's go back to the cellular mechanics. The goblet cells in the lamin are producing endless amounts of thick mucin jelly.
Right.
That mucin accumulates inside the lumen of the appendix. As the volume increases, the pressure builds.
The physical hydrostatic pressure.
Right. The tumor doesn't tear through the tissue with enzymatic destruction. Instead, the sheer physical force of the accumulated jelly pushes against the appendix wall.
It just stretches it.
It slowly stretches the inner lining, thinning it out, flattening the normal architecture, until the jelly literally pushes its way through the muscle layers, separates the fibers, and eventually ruptures the outer serosal lining of the organ.
And once that outer lining pops, the massive volume of mucin and the tumor cells floating suspended inside it spill freely into the abdominal cavity.
Yes, and even though the individual cells look low-grade and relatively benign under a microscope, their ability to harness physical pressure to breach the organ, spread throughout the entire abdomen, and cause a fatal crushing condition makes them functionally, biologically malignant.
That is why the AJCC changed the classification.
Exactly. We cannot underestimate a tumor just because the cells look quiet if the end result is a lethal dissemination.
That is terrifying. Now, as I was reviewing the new AJCC staging tables for LAM, I noticed some real weirdness in how they handle the T categories.
Yes, the T staging is very unique.
For the listener, the T stage in cancer usually describes how deep a primary tumor has grown into the wall of the organ. T1 is usually superficial, T2 is into the muscle, T3 goes through the muscle, etc.
Right, that's standard.
But for LAM, it skips the early stages completely. There is no T1 or T2. It jumps straight from TIS, meaning tumor in situ confined to the inner lining, to T3 or T4. Why erase the middle stages?
It is entirely because of that pushing invasion we just discussed. In a normal colon cancer, a pathologist can see a T1 tumor invading the submucosa and a T2 tumor invading the muscularis propria.
Okay.
But in a LAM, the massive pressure of the mucin completely flattens and compresses and eventually destroys the mucosa and submucosa.
The balloon expands so hard it crushes the inner layers of the wall it's pushing against?
Exactly. By the time the appendix is removed and the pathologist looks at it under the microscope, those early anatomical landmarks are simply gone.
Obliterated.
The tissue has been obliterated by pressure. It is just a thin, fibrotic shell of muscle stretched over a lake of mucin. Because the pathologist cannot identify the submucosa, they cannot assign a T1 or T2 stage.
The tumor literally erases the evidence of its own early growth.
That is incredible, isn't it?
That is wild. The physical mechanics of the tumor defy the standard rules of pathology.
They do.
And speaking of defying rules, there is another critical quirk in the new guidelines regarding peritoneal spread. Let's say the pathologist is examining the appendix, and they find mucin on the absolute outside of the organ, on the serosa.
Okay.
In almost any other cancer, if you find tumor cells on the outside surface of an organ, that means it has metastasized. It's an advanced stage.
So that's the general rule.
But the AJCC instituted a highly specific rule for LAM. What is it?
The rule states that even if there is mucinous epithelium found on the outside serosal surface of the appendix, if the tumor cells have not actively penetrated the muscular wall, the muscularis propria, it is still staged as titis, or tumor in situ.
Wait, hold on. If there is jelly and tumor cells on the outside of the organ, how is it not invasive? How did the jelly get out there if it didn't invade through the wall?
This is where pathologists have to act like forensic scientists reconstructing a crime scene.
I love that.
If there is no evidence of the tumor pushing through the muscle, the logic dictates that the spread was likely due to a prior physical mechanical perforation of the appendix.
Like an episode of acute appendicitis a year ago that caused a microperforation.
Precisely. A tiny hole opens up due to inflammation, some mucin leaks out onto the surface of the appendix, and then the patient's immune system manages to heal and seal the hole over.
So the mucin on the outside is the result of a mechanical leak, an accident, not biological invasive metastasis.
Exactly. Because the tumor didn't biologically drive the spread through the wall, it remains staged as non-invasive or in situ.
It is incredible how nuanced this pathology is. Every detail tells a story about how the tumor interacts with the host.
It's fascinating.
Okay, so we have the definitive pathological diagnosis. We have the updated AJCC stage. Now, the multidisciplinary team, the surgeons, the medical oncologists, the pathologists, must sit down in a tumor board meeting and make a high-stakes clinical decision.
The most critical decision.
The patient is sitting at home recovering from their appendectomy. The question is, was that appendectomy enough to cure them, or do we need to bring them back to the operating room and remove half of their colon?
This specific decision point is one of the most heavily debated and analyzed topics in surgical oncology today. The guidelines are strict, but the biology can be messy.
Let's outline the gold standard criteria to provide clarity. Let's start with the scenarios where it is definitively safe to stop at just an appendectomy. When is the appendix enough?
First, if the pathology returns as a LAMN that is entirely confined to the appendix, and the surgeon achieved completely clear surgical margins, meaning there is no tumor tissue at the cut edge where the appendix met the cecum, an appendectomy is 100% curative. You do not need to do anything else.
Simple enough. What about the non-epithelial tumors, the NETs?
For neuroendocrine tumors, if the tumor is less than 1 centimeter in size and it is located near the tip of the appendix, away from the base, a simple appendectomy is sufficient.
And there's one more specific rare subtype mentioned in the literature, goblet cell adenocarcinoma.
Yes, goblet cell adenocarcinomas, or GCAs, are a strange hybrid tumor.
Hybrid.
They have features of both neuroendocrine cells and mucin-producing epithelial cells. They're very aggressive. But if a GCA is caught incredibly early, is less than 1 centimeter, and has absolutely no aggressive features, like invading the nerves or blood vessels, a simple appendectomy might be sufficient, though this is heavily debated and requires intense follow-up.
Okay, so that is the conservative route. What about the right hemicolectomy criteria? When do we have to go back in, open the patient up, and take the right side of the colon?
The indications for a right hemicolectomy are based on the risk of the cancer spreading to the local lymph nodes. If the tumor has a high risk of being in the nodes must come out.
Let's list the triggers for that surgery.
For NETs, if the tumor is greater than 2 centimeters, you must do a right hemicolectomy. If it's between 1 and 2 centimeters, it's a gray area that depends on other aggressive features, but greater than 2 centimeters is an absolute mandate.
What about the adenocarcinomas?
For any invasive non-mucinous adenocarcinoma, which, remember, behaves just like standard colon cancer, you need a right hemicolectomy because the risk of lymph node spread is very high. And for any goblet cell adenocarcinoma that is greater than 1 centimeter or has nerve invasion, you need the larger resection.
I want to pause here and explain the anatomy of a right hemicolectomy for the listener.
Okay.
Because I think a lot of people might wonder, if you are just worried about the lymph nodes next to the appendix, why can't the surgeon just go in, make a small incision, and delicately scoop out the specific lymph nodes? Why do they have to remove a massive functional piece of the large intestine?
It is a profound anatomical constraint. It all comes down to the vascular anatomy of the right lower quadrant.
The blood vessels.
Yes. The appendix, the cecum, and the ascending colon do not have separate blood supplies. They all share a single common arterial trunk, the ileocolic artery.
Like branches coming off a single main water main?
Exactly. Now, the lymphatic system, the network of vessels and nodes where cancer cells travel first, runs perfectly parallel to that arterial blood supply. The lymph nodes that drain the appendix are embedded in the fat surrounding the main trunk of the ileocolic artery.
I see where this is going.
To safely, cleanly, and completely remove that entire lymph node basin for accurate staging and potential cure, the surgeon cannot just pluck out individual nodes.
They'd hit the blood vessels.
They would cause catastrophic bleeding and likely leave microscopic cancer behind. The only oncologically sound way to remove the lymphatic basin is to cut the ileocolic artery right at its root, taking the fat, the nodes, and the artery in one block.
And if you cut the main water main at the root, all the branches lose pressure. The cecum and the ascending colon lose their blood flow.
Precisely. The bowel supplied by that artery will immediately become ischemic and die. So by sheer oncological necessity, if you need the lymph nodes, you have to sacrifice the right colon and the terminal end of the small intestine.
Wow.
The surgeon then takes the remaining healthy small intestine and stitches or staples it to the remaining healthy colon, restoring the continuity of the digestive tract.
It is a major life-altering operation.
Which is why the criteria for who actually needs it are so strictly debated.
That makes perfect anatomical sense. You can't take the nodes without taking the blood supply, and you can't take the blood supply without taking the bowel.
Exactly.
This leads to an incredibly important scenario about intraoperative surprises. Let's do another what if.
Let's hear it.
A general surgeon in a community hospital goes in laparoscopically to do a routine emergency appendectomy for what the CT scan says is acute appendicitis.
Okay.
They place the trocars, put the camera in, and look at the screen. But they don't see a red, inflamed appendix. Instead, they find a massive sea of thick, translucent jelly filling the pelvis.
A nightmare scenario.
Mucin is coating the bowel, the liver, the abdominal wall. What is the absolute non-negotiable surgical protocol in that terrifying moment?
The absolute most critical rule for that surgeon is stop. Do not attempt a heroic resection. Do not start aggressively scraping or suction the mucin off the organs.
Wait, why not? The instinct of a surgeon is to remove the disease. If they see jelly, shouldn't they try to clean it out?
In a standard community hospital setting, attempting to clear that mucin is the worst possible thing they could do.
Really?
Mucin is incredibly tenacious. It adheres tightly to the delicate serosal lining of the intestines. If a general surgeon starts indiscriminately peeling and tearing mucin off the bowel loops, they will cause severe diffuse bleeding.
And microtears.
They risk creating microtears in the intestine, leading to leaks. But most dangerously, the trauma of that aggressive dissection will cause the body to form massive amounts of dense scar tissue, known as adhesions.
And those adhesions will basically glue all the intestines together.
Yes. And when that patient is inevitably referred to a specialized cancer center for the massive curative surgery they actually need, the specialized surgeon will open the abdomen and find a solid block of scar tissue,
making it impossible to operate.
The initial well-intentioned scraping will have rendered the patient technically inoperable. It ruins their chance for a cure.
So what should the community surgeon do instead? Just close them up?
They need to perform a highly controlled assessment. The protocol is to visually calculate the extent of the disease using a standardized scoring system called the Peritoneal Cancer Index, or PCI.
Just look, don't touch.
Exactly. They map out exactly where the mucin is located in the 13 regions of the abdomen. They might take a very small, safe, incisional biopsy of a mucin nodule on the abdominal wall to confirm the pathology.
And then?
If there's an acute bacterial infection or an impending bowel obstruction, they address that specific life-threatening issue. And then, yes, they close the patient up. That patient must be referred immediately, without delay, to a highly specialized peritoneal malignancy center.
Speaking of a sea of jelly, that brings us to the advanced, extreme frontier of this disease. What happens when a mucinous tumor erupts, the appendix bursts, and the cancer cells completely colonize the abdominal cavity?
We call that advanced clinical condition pseudomyxoma peritoni, or PMP.
Pseudomyxoma peritoni.
Yes, it is arguably one of the most terrifying, complex, and fascinating conditions in all of surgical oncology. In layman's terms, it is sometimes referred to as jelly belly.
What exactly is happening inside the patient in PMP? How does it kill?
When the LAMN, or mucinous adenocarcinoma, ruptures, the mucin-producing tumor cells spill out and implant themselves on the peritoneum,
which is the thin, sarin wrap-like membrane that lines the inside of the abdominal cavity and covers all the organs.
Yes, and these implanted cells continue doing what they're programmed to do. They pump out gallons and gallons of thick, gelatinous mucin. Over months and years, the abdomen swells massively. The jelly fills every crevice.
And because the abdominal cavity is a closed space, that volume has consequences.
Severe consequences. The sheer physical pressure of the accumulating mucin eventually compresses the stomach, so the patient can't eat.
Oh, wow.
It crushes the loops of the small intestine, causing fatal bowel obstructions. It compresses the diaphragm, making it impossible to breathe. PMP doesn't usually metastasize to the liver or the lungs through the blood like colon cancer. It kills locally through mechanical crushing and starvation.
And earlier we talked about how traditional IV chemotherapy doesn't work well because the genetics are different. But reading the literature, there is another purely physical reason why giving a PMP patient IV chemotherapy is essentially useless, right?
Yes, there is a profound mechanical barrier. Mucin is avascular.
Meaning it has no blood vessels growing through it?
Exactly. It is just a massive lake of biological jelly. When you give a patient intravenous chemotherapy, the toxic drugs travel through the patient's bloodstream. exiting the capillaries to attack fast-growing cells.
But the jelly doesn't have capillaries.
Because the mucin lake has no blood supply, the chemotherapy physically cannot reach the tumor cells that are floating suspended deep inside the jelly.
It is like trying to poison an enemy who has locked themselves inside a sealed, bomb-proof bunker. The drug just circulates right past them.
That's a great analogy.
So if you can't attack the tumor systemically through the blood, you have to attack it directly. You have to open the bunker. Which brings us to the radical shake-and-bake solution.
CRS and HIPEC.
Let's get into it.
CRS and HIPEC represent one of the most extreme procedures in modern medicine. CRS stands for cytoreductive surgery. This is a mammoth, grueling operation that can easily last 10, 12, sometimes 16 hours.
16 hours?
Yes. A highly specialized surgical team opens the abdomen entirely. They painstakingly, millimeter by millimeter, remove every visible speck of tumor and mucin.
But they don't just take the jelly, right? They take the lining, too.
Yes, they perform a peritonectomy. They literally strip the diseased peritoneal lining off the inside of the abdominal wall, off the underside of the diaphragm, off the liver capsule, out of the deep pelvis.
That sounds incredibly traumatic for the body.
It is. They may have to remove the spleen, the gallbladder, parts of the stomach, and sections of the bowel if the tumor is deeply embedded. The goal is to achieve a macroscopic, complete resection, leaving absolutely no visible tumor behind.
That is the shake, a massive surgical clearance. But even after 14 hours of meticulous dissection, the surgeon knows they didn't get everything.
Because no surgeon's eyes are good enough to see a single microscopic cancer cell. There is always residual microscopic disease left behind. If you just close the patient up after CRS, the cancer will inevitably grow back.
So to kill those invisible cells, you need the bake.
HIPEC. Hyperthermic intraperitoneal chemotherapy.
Explain how that works.
Once the surgeon has completed the CRS, they place large tubes into the patient's abdomen and temporarily sew the skin closed. They connect those tubes to a specialized perfusion machine.
And what does the machine do?
The machine pumps a heated chemotherapy solution, usually high-dose oxaliplatin or mitomycin C, directly into the abdominal cavity.
They literally fill the belly with liquid chemo.
Yes. The fluid is heated to about 42 degrees Celsius, which is roughly 107.6 degrees Fahrenheit. The machine circulates this hot, highly toxic fluid continuously throughout the abdomen, washing over all the exposed tissues for 60 to 90 minutes.
The heat aspect is fascinating. Why heat it? Is it just to burn the cells? To explain how HIPEC works on a molecular level, I want to bring up a really recent, brilliant study published in the International Clinical and Medical Case Reports Journal.
Yes, the animal model study by Dr. Wang and colleagues. It provides incredible mechanistic insight into why we heat the drug.
Exactly. They wanted to prove the efficacy of this exact treatment. They took nude mice, which are mice genetically bred to have no immune system, so they don't reject human cells, and injected their abdomens with human appendiceal mucinous neoplasm cells, specifically a highly aggressive cell line called AMNL2.
This created a perfect miniature model of PMP.
Right. Then they treated the mice with oxaliplatin heated to exactly 42 degrees Celsius for 60 minutes, just like in a human HIPEC.
And the macroscopic results were dramatic. After the treatment, the volume of ascites, the malignant fluid in the mice's bellies, dropped by an astonishing 57.8%.
Cut by more than half.
Furthermore, the actual number of solid peritoneal tumor nodules decreased by over 60%. The hot chemo clearly decimated the cancer.
But the best part of the paper is why it worked. They looked at the proteins inside the dying cancer cells. Can you explain the mitochondrial apoptosis pathway they discovered? Because this is where the biochemistry is truly elegant.
Absolutely. Apoptosis is the scientific term for programmed cell death. It is the cell actively committing suicide in an organized way.
Okay.
The researchers analyzed the protein expression inside the AMNL2 cancer cells immediately after the heated chemo treatment. They found that the HIPEC dramatically upregulated, meaning it increased the production of a protein called cleaved caspase-3 and another protein called BAX.
Okay, let's use a mechanical analogy here. If the cell is a car, what are caspase-3 and BAX?
Caspase-3 and BAX are the cell's internal self-destruct mechanism. They are the accelerator pedal for apoptosis. When BAX is activated, it punches holes in the cell's mitochondria, releasing toxic chemicals into the cell.
And that triggers the next step.
Yes. That activates caspase-3, which acts like a molecular shredder, literally cutting the cell's DNA to pieces. HIPEC forces the cancer cell to slam its foot on this accelerator.
But cancer cells are famously hard to kill. They must have a defense mechanism against this.
They do. In the same study, the researchers noted the levels of a different protein called BCL2.
BCL2.
BCL2 is an anti-apoptotic protein. Its entire job is to block Bax and stop caspase-3. It is a cellular brain pedal that prevents suicide. Cancer cells usually produce massive amounts of BCL2 to ensure they survive chemotherapy.
But what did the HIPEC do to BCL2?
The heat and the oxaliplatin synergistically downregulated BCL2. It completely crashed the levels of the survival protein.
So, extending the car analogy, HIPEC is a dual-action weapon. The heat physically damages the cancer cell membrane, making it permeable so the chemo floods in. Once inside, the chemo cuts the brake lines. It destroys BCL2, the survival protein. Simultaneously, it drops a brick on the accelerator. It massively upregulates caspase-3 and Bax. The cancer cell has no brakes, full throttle into programmed suicide.
That is a brilliant way to visualize it. By combining extreme heat with direct contact, we bypass the avascular mucin barrier, force the drug into the cells, and completely overwhelm the tumor's biological defenses.
It's just incredible.
That is the true power of CRS and HIPEC. It is brutal on the patient's body, but it is deeply elegant on a molecular level.
It's an incredible testament to the combination of sheer surgical endurance and precise molecular targeting. But as we move towards the end of our deep dive, let's pivot to the opposite end of the spectrum.
Because not every patient needs this.
Right. Not every patient who is diagnosed with an appendiceal tumor needs to have their abdomen laid open and bathed in heated chemotherapy.
Correct. For early-stage disease, that would be massive overtreatment, carrying huge risks of morbidity and mortality.
Let's go back to the patient with a LAMN. Suppose it's caught early, the appendix is removed intact, but the pathologist finds a tiny bit of mucin strictly on the outside of the appendix.
The microperforation scenario.
Yes. As we established, it's staged as in situ because it hasn't invaded the muscle. But the word tumor and jelly on the outside still sounds utterly terrifying to the patient. Do we rush them to surgery just to be safe?
Historically, yes. Many surgeons would advocate for taking them back to the OR to do a retinomectomy, or at least an exploratory laparoscopy.
Right, that's changing.
We are currently seeing a major data-driven shift towards conservative management in highly selected patients. Let's look at a pivotal prospective study out of France that focused on a strategy called active surveillance.
Active surveillance, meaning just watching and waiting. Tell me about the cohort. This must be a very specific group of patients.
They studied 30 patients over a decade. All of these patients had an incidentally diagnosed LAMN discovered after a routine appendectomy. But to qualify for the active surveillance study instead of immediate surgery, they had to meet an incredibly strict inclusion criteria. First, they had to have completely normal tumor markers in their blood.
Let's define those markers. The study mentions CEA and CA19-9. What are those?
CEA stands for carcinoembryonic antigen, and CA19-9 is carbohydrate antigen 19-9. These are proteins that are normally present in fetal tissue, but in adults, they are often shed into the bloodstream by gastrointestinal tumors, particularly colon and pancreatic cancers.
So if the numbers are high, the tumor is active.
While they aren't perfect, if an appendiceal tumor is aggressive and spreading, these numbers often climb. So normal blood markers were a hard requirement.
What else did they need?
They had to have a completely clear, high-resolution abdominal MRI showing no visible mucin anywhere else in the belly. And crucially, the pathology report from the initial surgery had to confirm that the spilled mucin was localized strictly to the immediate periappendiceal area, nowhere else.
So early stage, highly localized, chemically quiet tumors. What was the protocol for watching them? Because watching sounds passive, but in oncology it rarely is.
Oh, it was a rigorous, demanding protocol. The patients underwent comprehensive physical exams, blood tests for those CEA and CA19-9 tumor markers, and high-resolution MRIs at 6 months post-op.
And then?
Then they had to repeat that entire battery of tests every single year for 10 years. Some patients also required interval colonoscopies.
A decade of anxiety, waiting for the MRI results every year. What was the outcome of the study? Did the tumors come back?
The results strongly validated the approach for this specific group. Over the course of the 10-year study, only 13%, just 4 out of the 30 patients, showed any signs of disease progression or new mucin accumulation that required surgery.
Wow. Think about what that means.
Well, it's huge.
For 87% of those patients, they completely avoided a radical life-altering surgery, like a right hemicolectomy or the massive trauma of CRS and APEC. The preservation of their quality of life, the avoidance of surgical complications, it's immeasurable.
It is a massive victory for conservative management. However, and I cannot state this caveat strongly enough, The success of this approach is entirely dependent on absolute, unwavering compliance to the surveillance schedule.
Right. Active surveillance is not ignore it and hope for the best.
It is a highly active, medically demanding protocol.
Because if the tumor does decide to progress in year 4, you need to catch it on the MRI the very moment it becomes visible, while it is still curable.
Precisely. If a patient misses 2 years of MRIs because they moved or lost insurance, and the mucin spreads quietly, by the time they become symptomatic again, they might have inoperable PMP.
That's a really good point.
The psychological toll of 10 years of scanxiety is real. If a patient cannot mentally or logistically commit to annual MRIs and blood draws for a decade, then active surveillance is actually the most dangerous option for them, and prophylactic surgery might be safer. It is a deeply personal, complex decision made between the patient and their oncologist.
As we wrap up this deep dive, let's quickly recap the broader prognosis for appendiceal tumors. Because we've talked about indolent NETs and fatal PMP. Where do the survival statistics land?
The statistics vary wildly, almost entirely based on the histology and the grade of the tumor. For low-grade tumors, like LAMNs that are completely confined to the appendix, and small localized neuroendocrine tumors, the prognosis is genuinely excellent.
What are the numbers?
We're looking at 5-year overall survival rates between 67% and 97%. In many cases, the initial appendectomy is a definitive cure.
But the other side of the coin.
Yes. For advanced mucinous adenocarcinomas, or tumors featuring aggressive signet ring cells that have already ruptured and spread to the peritoneum, the prognosis is incredibly grim. Even with radical surgery and HIPEC, the 5-year survival rates plummet to between 10% and 25%.
That's devastating.
This stark contrast underscores exactly why early detection, meticulous pathology grading, and immediate referral to specialized peritoneal centers are so incredibly important. A delay in diagnosis can shift a patient from a 97% survival bracket to a 10% survival bracket.
So what does this all mean? We started this journey looking at the appendix as an evolutionary leftover, a useless little vestigial organ that only exists to cause trouble.
And we found something much more complicated.
Right. We've unpacked that it is actually a highly complex biological ecosystem. It's capable of harboring genetically unique tumors driven by completely different KRAS and GNS pathways than the rest of the gut that possess the terrifying physical ability to hide behind the exact mask of common acute appendicitis.
It is a disease that demands humility from clinicians. It requires emergency physicians, radiologists, and surgeons to constantly maintain a high index of suspicion, especially when dealing with patients over 40 who present with complex appendiceal abscesses. We cannot let the noise of the inflammation blind us to the signal of the neoplasm.
I want to leave you, the listener, with a final forward-looking question to ponder.
Okay.
We've spent this hour talking about the limitations of our current tools. We talked about how the X-ray machine is broken, how CT scans generate false positives 80% of the time, and how the surgeon's eyes are literally blinded by pus and edema in the ER.
All very true.
We also talked about the NCI study proving that these tumors have a unique identifiable genetic fingerprint. So as genomic sequencing technology like the Foundation Medicine tests gets cheaper, faster, and more ubiquitous, what if we eventually stop relying on standard gross pathology and imaging altogether?
That is a profound paradigm shift to consider.
Think about it. What if 10 years from now, the standard of care is to take a tissue sample from every single inflamed appendix removed in the emergency room, drop it into a sequencer, and run a rapid genetic panel?
Instead of waiting for a pathologist to squint through a microscope to spot a few abnormal goblet cells hidden in the sea of necrotic tissue.
Right. What if a machine catches the molecular whispers of a KRAS or GNS mutation years before the first drop of mucin ever escapes the appendix wall? Could we theoretically eradicate conditions like PMP before they even have a chance to begin?
If the technology becomes cost-effective and rapid enough, it would completely revolutionize gastrointestinal oncology. We would move away from reactive, massive salvage surgeries and move toward true, molecular-level prevention and definitive early cures.
It's a future where the genetic code entirely replaces the surgeon's eyes. Thank you for joining us on this deep dive. Keep questioning the consensus, keep looking closer at the details, and remember that sometimes the most complex, systemic mysteries are hiding in the most unlikely, seemingly useless places in the human body. We'll see you next time.